Hello, everybody. My name is Dr. Alex Rubinov. I'm a New York City-based dentist. I'm really happy to be a part of Megagen's online education series as to how we can minimize chair time. And so I'm going to share several cases today about how these things play a role, how implant dentistry plays a role in my practice, and how really the anterior cosmetic aspect from a single unit to laterals to a full smile makeover, and how I incorporate surgery into the whole flow of everything, and then finishing it off with a full arch implant case. For me, I think it's setting up the restorative to be easy from day one, and that's really what I'm going to show you. So I'm going to go ahead and share with you my lecture. Here we go. Awesome. So I graduated from Columbia Dental School. I am a third-generation dentist. My grandfather and grandmother practiced in Russia. My father practiced in Russia and then came to the States about 30 years ago and went back to dental school here. And I would enjoy spending time in his office. And now I am practicing alongside him and have my own practice in New York City. I've been a Minnick Knight since 2018. And you can find me at Dr. Alex NYC on Instagram or my website or whatever else it may be that you want to look at some of the work that I've done. So I'm going to share 4 cases. And I'm going to start with the first one is the immediate implant placement of a central incisor and really how to set yourself up for success for the future. I really think that it's all about understanding the tissue. Obviously, we have socket shield techniques now where maybe we would do it a little differently to not lose the architecture, but this is just understanding the basics of how to do it traditionally allows you to then push the envelope and do socket shield techniques. So here is what the patient's presented. Here is external resorption on the top and otherwise fractured all the way to the gum line. What is really important understanding in these cases is where the bone is and where the bone isn't. And so understanding the incisive canal is critical. As we go from the one side to the other side, you're seeing the incisive canal gets larger and larger, whereas almost it's huge on the right side. So the most important part is doing an atraumatic extraction. So leading to an atraumatic where the papilla are still in place, and then starting and avoiding the incisive canal and placing your initial osteotomy. Obviously, at this point, you should all take an X-ray to make sure that you know exactly where you are, where you can go, how close the adjacent teeth are, and then so on and so forth. But the other important part is making sure that you drill right at the cingulum, because the idea here is to have a screw retain restoration always, whether it's from the temporization all the way to final restoration. So I always angle and position my implants in the anterior so that I can get a screw retain crown on there. Obviously, the tissue on the one all the way to the left, you can see needs some support. So if you just put a healing abutment on there and let the tissue heal, all that tissue would collapse. The important part is to keep and maintain that. And so how do you do that with a temporary? So this concept of S-shaped temporaries is critical. You need to understand that when you have the implant in place, you put a healing abutment, you put a temporary abutment cylinder onto the implant itself. You put a temporary abutment onto the implant, and whether you're using an alginate impression or a putty index, whatever material you're using that has the shape of the tooth to adhere to the abutment. But originally how it comes out is obviously not smooth, rigid edges, and the key is just to get it bound to the abutment, the bisacrylic bound to the abutment itself. So then it's creating the architecture of this S shape of the abutment to the tissue, but everybody's case is different because there's a different gap between the tissue and where the implant is. And so in order to have the sufficient amount of bone placed there, you really have to create the architecture of this temporary. Once you finish designing the temporary, you can move on to the next thing, and that's filling the bone in into the gap. So then you pack the bone in, what material you use. I like corticocancellous bone graft. And then I'm able to just pack that bone in there, remove the healing abutment or cover screw, whatever you have on during that time, because you don't want any of the bone to get into the implant. So you have something covering that area at the time. Put all that bone in there, remove the cover screw or the healing abutment, and then you could go ahead and, since you already designed the temporary, you place the temporary, pushing the bone and the tissue back into the place that you want it. That's the most important part, is creating the temporary before you put the bone in. And having the right occlusal schemes, so that you're making sure that there's absolutely no excursive movements, anterior, posterior, sliding back and forth, that there's absolutely no touching of this implant temporary crown. And so you relieve all of it, all the prematurities. As you can see, you use articulating paper and you let it heal. Take an X-ray, either at 6 weeks, 3 months, and you look. And the idea is to take off the temporary and have the architecture of the original tooth, because every central is different, right? Whether it's oval in shape, whether it's round, whether it's more of a square rectangle. I mean, the idea here is try to mimic nature as much as possible, because then you put then once you take the impression right there, you have everything. You don't need to work up the tissue. Look at how the architecture of the tissue originally during the day of surgery was falling, but because we had a temporary to hold that tissue up, we got a beautiful architecture. So when we look at the final restorations of all of these, we see from the incisal edge position that the architecture of the tissue is maintained. And that is huge, and that's in part to creating the temporary chair side and following the S-shaped curve that really needs to be in place in order to get a good result. It has to be smooth. You have to polish it. That's where I think the chair time saved in the future, because you go ahead, you put the impression coping in, you could fill it in with, either you take a scan of the tissue or you fill it in with composite, take an analog impression, whichever technique you use, immediately it gives you great results. And you don't have to, the patient's never in pain. There's no guessing game of where the tissue will be. Everything is already predicted. So when you, as opposed to taking a healing abutment off and then having to generate the tissue and redesign the tissue position, it's much different. So I strongly encourage this with any immediate surgery in the anterior zone. And obviously you can see that the tissue architecture has been maintained from the start. Let's go to an aesthetic case. Patient came in, said, I haven't been to a dentist in 7 years. He's like, I had an implant placed in the front tooth. I haven't been back to that dentist. I haven't seen anybody. I haven't done any work. So I'm going to walk you through the process of how I save time and create the most excitement and emotions from the patient. So a lot of dentists would say in a case like this, oh, let's extract the teeth, let's put the implants in, and when the implants finally are ready, then we're going to do a smile makeover. But that's not what I do. My approach is, how can I give them the immediate gratification so that they can smile and be happy from the beginning? And then as everything else plays into roles, then we get into it. So the first appointment is diagnostic. Second appointment, within a week, while I have the impressions and the wax up of the case being made by the lab, I saw him at the second appointment, and that's to start the surgeries. Surgeries in this case, tooth number on the upper right, number 3, was extracted. He had a lot of infected bones, so I added, he had a periapical pathology there that was acute, so I needed to relieve that and just pack it with a bone. Whereas at site number 12, upper left, I did an extraction, immediate implant placement, and bone graft. And so obviously that site will be ready about 3 months, whereas site number 3 needs to be ready in about 6 months, because we got to wait for the bone to mature first. And after the bone matures, then we could place the implant. So why would I wait 6 months for a patient to get a smile makeover just because we're waiting for implants to heal. That doesn't make sense. That's the beauty of doing the restorative and the implant surgery all at once, or being the clinician that can sort of be the quarterback for that. And then I did a connective tissue roll on the implant in the anterior. Basically, I tried to get the information from his old dentist. They didn't have it on record. So, and you could see the shadowing of the tissue coming through in the implant site number 10. So I wanted to do a connective tissue roll. And what I do with connective tissue rolls is I extend the incision on papilla-sparing incision. This is an external hex 3i that was placed now over 10, 12 years ago. And I extend the incision all the way onto the palate so that I can have de-epithelialization of the tissue. And that's what allows me to take the excess tissue and roll it onto the buccal to make that tissue thicker, so that we can get good emergence, so that we can have extra tissue, so that we can support the implant with tissue, because we know tissue is an important part of this game. So that was all done on week 1. When I saw him, I put a temporary abutment in there to let the tissue start healing around it. Appointment number 3 was 2 weeks after I saw him. Everything started to heal already. And what did I do? So we prepped the upper 8 teeth, because initially the patient didn't want to do anything on the premolars on the right. So we prepped some for crowns, some for veneers, and then in the area of tooth number 12, upper left, I prepped for a crown around the tooth, so that it's going to be a pontic cantilever going over to upper left premolar. So as you can see, these are veneer preps in the lower anterior, upper are crown preps, and the canines are veneer preps. This is 2 weeks after I met the patient. This is what he walks out with. Temporaries on the top, temporaries on the bottom. Immediate gratification. If we were able to do the top right from the start, I would have been able to bring the smile line down and create less of a cant, but unfortunately, he wasn't ready at that time. But the beauty, and I'll share with you, of getting an immediate gratification and excitement for the patient is that once you give them this dream that they've wanted for a long time, they're yours, right? They're your patient. They will start listening to you more. And so we did the bottom 6 veneers and the top restorations with the implant crown for the external hex. And then the cantilever is over here on the right, as you can see, so that while the implant heals on the top left, tooth number 13 is acting as a cantilever. Eventually we'll section that. And that's actually made out of, it's not a temporary crown, it's a monolithic zirconium coping with PFZ over it, so temporarily cemented. So it's a final restoration, but in this he used it as a temporary solution, because I don't want to have a patient break the temporaries. I know it's going to be there for at least 3 to 6 months, so I don't want the temporaries, the discoloration. The key is to get the patients as pleased as they can right from the beginning. So a month after I met him, this is what he looked like. Just a month after I met him. I mean, you know, then what happened is we prepped the top right. He's like, you know what? I love my smile. Let's go ahead and prep the top right. Let's build out the buccal corridor on the right a little bit more. Let's have the matching of the color to the tooth. And like I said, because you did this for the patient, they love their smile, they start trusting you more and you start making recommendations. So 6 months after I met him, now we're starting to restore the implants. Tooth number 3 is an implant crown. In front of it is a crown. In front of that premolar is a veneer onlay. Really got rid of an old amalgam filling, and then you make a veneer onlay on top. On the opposite side is a screw retained implant crown, and then a single unit implant crown as well. So this case literally has every kind of restoration, from inlay veneers to regular veneers to crowns to screw retained implant crowns to traditional, has everything. So this is what he started within 6 months. I mean, can you imagine having him go through this process and only at 6 months he starts seeing results? For me and my patients, this is what I try to do. I try to escalate as fast as I can doing quality, good dentistry. And in his case, he needs to be maintaining oral hygiene. He's seeing the hygienist every 3 months. Obviously, we then, after this has been 4 years now, he is happy. He loves his smile. You can just see it in his eyes. He's a completely different human being. And that happened from month 1. So all this waiting for the implants to heal, to place the implants, it didn't bother him because he already had a gorgeous smile. Everything else was healing. So I think that is how I save not only myself chairside, but also my patient's time, because I try to push the envelope as much as we possibly can. I want to go into a congenitally missing lateral incisor case. I think this is really important about how to handle. At this point, he was 16 years old, wasn't ready for implants. My father had finished the orthodontics. He had a retainer with 2 false teeth in the front. Eventually, he was tired of having the metal wire. So then we made Maryland bridges on the anterior, which could have been final restorations, but both him and his family really wanted to get the implants done once he turned 18. So we take an X-ray of the wrist. We make sure that everything is fused, the bones are fused, the growth plates have fused, and there is no more growth for him. So then I'm comfortable placing the implants at that point. So this case, I'm going to walk you through. This is going to be the surgery. You're going to watch how we do the incisions, the implant placements, and then I'll show the bone graft. Because obviously in these congenitally laterally missing cases, the patients have huge defects. So we have to add a lot of bone to really know, to get a predictable result and really change the architecture of the bone there. So watch this. Here's what we did. So I think the incision is one of the most important parts here. You need to have vertical incisions going up deep into the vestibule. You need to have mid-crustal incisions. The idea is to not tear the tissue and try to keep it intact as much as possible. So we're going cleanly everywhere around, mid-crustal incisions. And as you see around tooth number 6, distal to the papilla, we are going to do a vertical incision. Obviously, the base of the incision needs to be wider than so that always make your incisions wider at the base and more narrow at the incisal position. So that is the incisions. Then when you do the flap, the key here, as my mentor Scott Gans mentioned to me when I talked to him about this case, is you have to make sure that you reflect the tissue all the way to the base of the bone, nasal passageway bone. Because if you start placing the bone graft too incisally, you're not going to have a predictable result. You need to really reflect that tissue very deep. And that's where, because the concavity goes like this, it's a little more wide at the crest, it goes deep in and then it goes back up. So if we could close that triangle and create a bone to form there, you have to go really high up into the incision. So obviously this is where we're going. You see that concavity. You'll see it in the photos right there. So the reason we're going all the way up to the base is because we want to fill that all with bone. Now we're using a surgical guide with VersaBurs. So it's a C guide. We have to start with initial osteotomies and make sure that the fit of the guide is perfect. And then we go ahead and we start making our initial osteotomies. Now I usually go about 6 millimeters. After the first 6 millimeters, I use guide pins, take an X-ray, make sure that everything, path of insertion is correct, make sure that we're not anywhere near the teeth adjacent to them. Obviously, in this case, it's a narrow position. So this X-rays are critical to make sure angulation of your implant is ideal and absolutely perfect. As well, we want to make sure we are at the incisal, or beyond the incisal edge position and are angled towards the cingulum. You really want to make sure that you have that implant being placed towards the cingulum so you can get a screw retained restoration. I think That is hugely key. So we perform the osteotomies, then we place the implants. And so what you're going to see next is after the implants are placed, the left and the right side are slightly different. What do I mean by slightly different? Not necessarily the position of the implant. Actually, first of all, we're going to take the ISQ. So in this case, we took the ISQ of both the implants. You want to make sure to load them. You have over 70 ISQ using the Megagen system. So here we had, to make sure that you take the measurement from all 4 positions, from the buccal, the lingual, the mesial, and the distal, and really getting results from all over. And here we had 77 as the result. Put the implant healing abutment on, and we see a fenestration on the top right implant, whereas you don't see it on the top left. Here now is the key to treatment plan, to making sure that you treat this case correctly. So in review, from the top we go with proper incision, making sure that the flap is all the way at the base of the nose, using a guide to help you with the osteotomies, making sure that the guide pins you have in place at the cingulum of the adjacent teeth. Then once the implants are placed, I put healing abutments on in this case, and we're able to see that there is fenestration on one side where there isn't on the other. And so now this leads me into the grafting of the bone and what I do differently on one side versus the other side. So since there is no fenestration here, I'm using BioOss, a xenograft material, to bulk out the tissue. And remember how high we went with our flap? We are adding bone all the way up there. We want to add so much bone that it almost is too much. It goes beyond the eminences of the adjacent teeth. So after you put the bone and you pack it, I use pericardium resorbable membrane to create a barrier between the bone and the tissue. And then afterwards, I secure it and I use PRF to just lay over the membrane so that it just holds everything there. But that's not the most important part, and keeping everything held together, that's just keeping it there during the surgery and obviously helping things from moving around. But the suture is the way to go. On the opposite side, we had fenestration. So we needed to place cortical bone first over the top of it, and then I packed it with BioOss later on, right after I placed cortical cancellous bone that's directly touching the implant. So we placed the exact amount of bone on both sides, packing it up really high towards the nasal cavity, as well as all around, and having a mound of bone around there. The key is just making sure that you have a lot of bone. And then you follow the exact same protocol on the opposite side, put a pericardium membrane, followed by PRF to cover the area where the implant is. And now we're going to keep the membrane held down there with PRF membrane. You can't just do this without PRF. You really need PRF. You can't do this without pericardium membrane, a resorbable barrier, because you want to protect the bone from the tissue to make sure that you don't have resorption. So, but all these are really important. Now you use PTF suture, non-resorbable suture, to make sure that you go into a deep vertical mattress. So you start really deep on the buccal, and then you finish, and then you have 2 entrances and exits out on the lingual, but you have to go really, really deep onto the buccal aspect, all the way above into the mucosal area, so that you tie, and you'll see as I suture it, the tissue just going to come all the way down just from the suturing. But it's not because there's tension on the tissue, but because you're so deep up into the vestibule that you're pulling all of that area down. And we'll show you as I do the other side, when you start moving around the tissue, that there is the lip, that there isn't any movement of the free tissue that will later be sutured with another material. So you see the same thing happens on the opposite side. Go really deep and bring that tissue down with the suture. This is PTFE, non-resorbable, and you want to make sure that the tails are really long, because otherwise it may be hard to find it. So you'll notice that on the PTFE sutures, the tail's really long, and here we're moving the tissue so that there's no movement. So then you see everywhere else I used resorbable chromic suture. On the vertical incisions, I had 3 PTFEs sutures, which I'll go over again with you. So here is, as you can see, one area is fenestrated, the other area is not. So the area that's fenestrated, we use corticocancellous allograft material followed by BioOs. In the other area, we just used BioOs. Then we put a resorbable pericardium membrane followed by holding everything together with PRF. And then the suturing. So I used the deep vertical mattress suture in 3 areas, up in the directly over the implant and in the middle as well, just to secure that area. And then the suturing everywhere else with chromic suture. So this is what the tissue looks like 2 weeks afterwards. Obviously, I put back the Maryland bridges that he had originally. I just secured them to the adjacent teeth. I didn't want to load this case immediately, but 4 months later, the tissue's healed and we are ready for final impressions. So remember what the architecture looked like originally. You see that there was a dip and a defect in those areas. There was no eminences, nothing there, no present. And now 4 months later, that tissue, because we packed so much bone, is now propped up. And so that's what he looked like originally. This is what he looks like with screw retained implant restorations, really fitting very nicely. And you don't have to have cement. You use screw retain and it's beautiful. It, you know, long lasting restorations that I think he will be happy that he did this can't predict how long this will go for, but you know, we monitor them every year. We take an X-ray, make sure there's no bone loss, and make sure that everything is still as good as it was on day 1. Lastly, I want to talk about immediate implant placement and prosthesis, and I think that working at the multi-unit abutment level is what is a must in these cases. It saves so much time prosthetically when you're done with the surgery, when you're ready to restore. It is non-invasive. The tissues is beautiful. So let me walk you through this process. So patient comes in, she has upper denture, lower partial denture. We end up doing both the arches, and I'm just gonna show you the lower arch first. So this is what she looks like. She has some teeth, she doesn't have some teeth. Obviously, in this case, I will use a tooth-borne surgical guide, but I will also at the same time extract teeth. So I'll show you the design of that. So I'm going to be having 5 implants in the mandibular region. The 2 distal ones are going to be angled so that we can get more of an anterior posterior spread. So the less flat line they are along the ridge, meaning the further apart we can have that anterior posterior spread by angling these distal implants, by having more of that. If you look at this square or rectangle, the reason that we're having more AP spread here is because we're able to angle these implants at 30 degrees, then restore with multi-unit abutments, getting the restorations to go up, vertical. But in this case, I need to design a surgical guide that would be tooth-borne, but at the same time not. So what did we decide to do? We decided to extract 4 of the teeth and section the bridge so that the guide can be over the premolar and over the freestanding tooth. So we can get 3 implants right there, and then behind those two teeth, we're able to drill the osteotomy for the rest of the 2 implants. And look at that posterior spread. That's what I'm talking about right there. The anterior line of those 3 implants, and then those last 2 implants up top give you more of the this spread up here that helps with long-term success of the restorations and of not putting too much pressure on the implants. So the guides fit well. You always have to make sure you try in the guides. Place the, those are the implant areas. Remember, we're angling, we're avoiding the nerve, the inferior alveolar nerve. And so those are the sites for the implants. So when we do the extractions, obviously then we have to flap the tissue and we place the implants. You see the anterior implants, some of them went into immediate extraction sites and the other two did not. And in the posterior, you see how those multi-unit abutments are now vertical and in line with essentially the anterior implants because we used a 30-degree abutment. Let me get into that a little bit. On a pano, you could see that's obviously I still use the guide pins to take an x-ray to make sure that I'm in the right place. I'm avoiding the nerve. You don't want to get into, you know, you really want to make sure that you're checking yourself at every stage of the game here. So the angled abutments can come in either 0 degrees, 17 degrees, and 30 degrees. And usually my posterior are angled so that I can get 30-degree abutments on there so that I get more of that AP spread. And so here on the bottom right, you can see the multi-unit abutments are all in place. And then we're working at fixture, at abutment level from here on out. You are never going to the implant again. Day one, you are putting the abutments in, multi-unit abutments, and you are working off of them. You can see this is day of surgery, putting just some healing collars on. And then while I'm doing the conversion, you use temporary cylinders to go directly attaching to the abutments. Then you fuse the temporary cylinders through the holes that the labs provided us to the denture, and I use a material, well, here's how it works. The implant connected to the multi-unit abutment, which is then connected to the temporary cylinder. And last, at the final stage of this, won't be temporary cylinders, it'll be final abutments that go over the final cylinders that go over the multi-unit abutments. So during the conversion here, I will fill in all those areas with chair side acrylic. So it's light curable. You don't have to sit there and wait. You literally inject it into the acrylic denture. Now it's fabricated by the lab. And then you can light cure it, and you can do that and that saves an enormous amount of time chair side by using a light curable acrylic material. I think that is huge and really valuable because then you can polish it, contour it, reshape it, so on and so forth. That is what the chair side acrylic allows you to do. You want to make sure you get rid of any undercuts so that it's a convex shape of the intaglio surface so the patient can clean, that there's no bacteria buildup, and they could use a water pick with this. And so that's what the X-ray looks like. And 4 months later, the bone is healed. We are ready for final restorations. I just don't think I have the photos in this case, but basically you're never going back to the implants. You are working from the abutment level. This will save an enormous amount of time when you need to just take impressions and accuracy and tissues. I mean, this is just a game changer, and I think is a total must when doing full arch dentistry. So those are a few cases that I wanted to share with you. I hope you enjoyed that. I hope you got something out of it. I want to say thank you to my father, who I practice with, Michael Apple, Larry Rosenthal, and Jay Lerner, who have all been mentors of mine, Scott Gans and Isaac Tawil, who I've been to Megagen implant plant with when I became a Minnick Knight in 2018, and obviously my ceramists, Jason Kim and Calvin Moon. So if you need me, don't hesitate to reach out. I am always available for questions, thought process. Really hope you enjoyed that and look forward to doing more things with Megagen. Thank you.